Welcome to this series of lectures on infectious and tropical diseases. And we have been progressing very well. I hope you have been enjoying it and has increased your interest in neglected tropical diseases. This is one of our aim that we should get some specialized personnel and specialized doctors, technologists in tropical diseases. As we have said before, reiterating that the neglected tropical diseases or the so-called neglected tropical diseases better now, is less neglected, and there are many achievements have been done before. Okay, malaria is not a neglected tropical disease. It's one of the big three, which is HIV/AIDS, tuberculosis, and malaria. And the cry came from the end of the 90s when malaria was ravaging and killing a lot of people, especially children below 5 and pregnant ladies. This is why a global fund has been created which supports malaria as far as treatment is concerned, as far as impregnated bed nets are concerned, and also HIV treatment and diagnosis, and tuberculosis mainly treatment. So the Global Fund has done a lot of good work. I, from experience, have witnessed how the drugs are being shipped. Even air freight is being paid for the countries who can demonstrate that the drugs can be used properly. Okay, malaria after the 2000, between 2000 and 2015, 60% of the malaria burden was taken out because of the new drugs, because of the impregnated net, and because of availability of diagnostics. To summarize last lecture, I would like to say that malaria is a febrile disease. It's a febrile protozoan disease of RBCs. So the parasite is in the RBCs, transmitted by the female Anopheles mosquito, which through seeking blood to lay the eggs can inoculate the parasite, which is sporozoites. That is the infective form. So it's a disease which is very widespread, and until recently it used to be in Europe, but it's been eradicated, especially Southern Europe. And luckily now some countries have really eradicated the disease, like El Salvador, Argentina, Algeria, Maldives Islands, Sri Lanka Islands, and others, which has done very well in eradication of malaria. So eradication of malaria is possible, is very possible. When there is heavy rain, rains usually leave ponds, and the ponds, stagnant ponds, are very good for breeding mosquitoes. And unless you have a very good system, then these mosquitoes can produce and can multiply. And in some areas, it's when the rain is only 3 months, then this is malaria is a rainy or during the rain only, like in Sudan. We used to have it during the autumn or the rainy season and continues for 3-4 months. And then it became sporadic, where there are some ponds which are unattended to. But in heavy rain, ponds can be created, but continuing heavy rain, can clean these ponds. So you can change the pattern of breeding, because once they get for 3-4 days no rain, the breeding starts, and then another heavy rain, it will clean the ponds and so on. So this is, if the rain is continuous, that will lead to less mosquitoes. In summary, of the disease itself, it is an acute illness. Generally, it's an acute illness. So it's fever, which comes abruptly, and it continues. Unfortunately, it can have a lot of complications, but we can look into the malaria as, the acute uncomplicated, and then we can the chronic malaria, and then we can talk about the complicated malaria, because as we said last time, malaria can be serious, can cause cerebral damage or edema, cerebral edema, and it can cause renal damage like acute kidney injury, and it can cause pulmonary edema, through the vasculature of the lungs, and it can cause, a lot of damage to the pregnancy. Okay, so this is what we call complicating form of malaria. But the classical form, which is being seen in the hospitals, in outpatients, this is a febrile acute illness, which starts with coldness. You feel cold, like you need blankets, and starts shivering, and this shivering can be very severe. Rigors, it's called rigors, and these rigors can be severe to the extent of teeth chattering, all right, and then you will be covered by blankets. After that, the fever comes. And when the fever usually lasts about a few hours, and then the sweating comes. Third stage is sweating. When you sweat, then the temperature subsides, and you feel fatigued. With nausea, and you may even vomit. The constant features of malaria is always the fever, the headache, and abdominal pain. You will have various abdominal disturbances. You may have vomiting, you may have diarrhea, you may have abdominal pain. So, and loss of appetite, all right? You feel lethargic and prostrated, that's the acute phase. And then the acute phase comes in paroxysm. It comes in paroxysm. We used to call falciparum malaria, which is one of the species, is tertium malaria. That is to say, the paroxysm comes every 3 days, tertium, 3. And then the other one, like vivax and malariae, these are quartan malaria, 4. But now this pattern has disappeared, because now we start treatment early, sometimes even without diagnosis. This is why the pattern of every third day or every fourth day has disappeared. But that is the general picture of the uncomplicated malaria. Treatment-wise, if a patient is mobile, he comes to the clinic, he's not with complication, better treat on outpatient basis. Okay, then, but you have to make sure that there is no complications, there is no consciousness problem, there is no drowsiness, and the rest of it. But once he goes into drowsiness or coma, certainly, this is a hospital case, if the patient starts with urea rising, or he has hypoglycemia, which are all complications of severe malaria, or he has cosmos breathing, like hunger breathing, which is caused by acidosis due to high lactic acid in malaria. So these are the indications, what we call severe malaria, needs hospital admission and needs extra care apart from the anti-malarials, because a coma patient needs, to be treated, especially patients with renal disease needs to be treated, especially. Hypoglycemia should always be sought out, because with malaria, especially if you give quinine or quinine, then hypoglycemia is a danger. So that is the outpatient and inpatient. Luckily, after the resistance to chloroquine, we are now using artemisinin derivatives, which are very effective, very rapid on its action, and it's have a wide window of activity. We will come to that. But so this is can be given, and there are different forms of artemisinin derivatives, and the best is to use in combination. Artemisinin derivative, either artemether or arsenate, with other components or other drugs like mefloquine, lumefantrine, and pyrimethamine or sulfones. These are combined in a fixed dose tablet, what we call ACT, which is artemethamine combined therapy or artemethamine combination therapy. So this has made a lot of change in the outcome of malaria. So let us talk about the parasite in one sense, the vector on another sense, and the human who receives and who gives the malaria, through the vector, and who receives a healthy individual who receives the malaria. There is a definite state of the vector, which is Anopheles mosquito. There is still methods of combating or eradicating the mosquito at the different stage of its growth. In the water, we use insecticide. This is we spray chemicals, and then through our knowledge that the mosquito gets out for breeding or for inoculation after sunset. So it's a night active vector. During the day, usually it is within the rooms. It is hanging within the rooms, within the clothes, dormant, hypnotized within the rooms. And once it's dark, they go out and then they start biting. So one of the insecticides which you can use is a smoke insecticide, like a smoke, and this is used during the day in closed rooms because it's light and it goes in the whole room, but then it climbs up to the ceiling and remains there, killing more mosquitoes. The other one is a razazi, which is called with moisture, and this can be sprayed by cars, along the streets, or even by airplanes. So that is how we can combat the mosquito. As far as the human is concerned, we know now there is immunity. There is immunity to malaria, and we'll come to that. So what can we do to the humans to contribute to the eradication of malaria is to start early treatment. And luckily, artemisinin itself has a very rapid action of clearing the ring form of the malaria and has an effect on the gametocyte, because a drug which does not affect the gametocyte will not influence the transmission, will not decrease the transmission. But artemisinin is one of those which can affect the transmission through the gametocyte. Then what is the immunity within the human body? The immunity is either innate immunity, which is built in, or acquired by exposing the human or immune system to the parasite. Okay, it is an RBC's protozoan infection. So if the RBCs is deformed in any way, then it will not accept the parasite. So there is a group, blood group, Duffy group. This is an antigen within the RBCs, which will reject the parasite. So there is resistance to the infection. Sickle cell trait, again, is another deformed RBC, which will prevent the malaria to be taken up. Ovaocytosis, oval RBCs, also are ones which will resist. So this is what we call an innate resistance. And then we have a resistance which is built in. You remember we talked about stable transmission and unstable transmission. Stable transmission is transmission all over the year, all over the year. And in that situation, those who are affected are children and pregnant ladies, mainly children and pregnant ladies, and some who have no immunity. So some people who are coming from areas which has no malaria, is they are less immune and they can catch malaria. But as they are staying in the stable zone of malaria, then they will have less and less malaria attacks. So that is what is built in. And this is seen clearly in the parasites being present, but there is no fever, there is no malaria. And this is what we call asymptomatic malaria, which is common if you go in the markets, supermarkets, or on the road, catching people and taking blood smears and then looking into the malaria. You'll find quite a number of patients who have parasite positive but has no fever. So these patients have developed a sort of immunity. And if these patients or these individuals, because they are healthy, harbor gametocytes, then that will guarantee the transmission. So the transmission will be going on through the presence of gametocytes, but the patient or the individuals are not affected by the malaria. So that is the sort of immunity. And when you talk about neonates, there is an antigen passing through the placenta to the neonates, which confers immunity to the neonate. And this is well seen because in the first year, definitely through the first 6 months, there is no patient, no neonate will get malaria, okay, or very little malaria in the early stages of neonatology. But then after the 1 year, then they get repeated attacks of malaria because then they don't have immunity. The immunity which was conferred from the mother it will wane away. It's been found that hemoglobin F, which is the hemoglobin the neonate will come out with from the mother with, is also protective against malaria. So there is an immunity stage. This is why in unstable or seasonal malaria, like in the one in autumn, then everybody will lose the immunity when the malaria goes away and then comes back. They have attacks of malaria. So this is what we gather. There is now a vaccine, okay, a vaccine, RTS vaccine, which is can be used, but it is of moderate potency. It is of short potency, and up to now it has not impacted the elimination and transmission interruption of malaria. So that is number one. But like you also to although you are not an entomology, but it's important because if you are a public health expert or you are in a position like public health officer in any place or even in hospitals, you can advise about interruption of transmission. Transmission has to be thought of like a circle, okay, from the vector in healthy individuals. The healthy individuals will develop the gametocyte, the vector will come again, the parasite will develop in the mosquito, and then it inoculate a new person. This is a circle, okay? And if you ever want to control a disease, you have to break this circle. The circle, instead of being circled, has to be a line. And once it's a line, it's terminated, okay? So it's either kill the mosquito or early treat the patient or vaccinate against further infection. I'm just summarizing what last lecture is all about. So the mosquito has to have a breeding sites, which is clean water, fresh water, it's not salt, cannot breed on the sea. That's number one. Stagnant water to give it time to breed. And then it needs an environment, and the environment is ambient temperature, which is between 20 to 30. Okay, above 33 degrees centigrade, so there is no breeding, and below 16 degrees centigrade, there is no transmission. So that is the area. If it is too cold, too hot, then it will not go on. Altitude, you need anything above 2,000, 2,000 meters above the sea level. There is no transmission. So these are the areas. These are the areas of the transmission, heavy transmission. So low areas, hot but not very hot, okay, and temperature will go down 16 down, which is the ambient, what we call ambient temperature. Okay, as far as the parasite is concerned, it's in the RBCs, and in the RBCs is the ring form. The ring form is like a ring on the head of the ring. So it's like a circle with a space between it, and then in that space there is a dot, which looks like a ring. So this is the ring form which is found in the RBCs, and in diagnosis of malaria, we look for the ring forms. Okay, for transmission in the blood, we look for the gametocytes. So the ring forms is the one which is the signal of presence of malaria. If there is clinical symptoms, then the presence of the ring form, this is malaria. Okay, what does it do in the RBCs? In the RBCs, it feeds on the hemoglobin. It feeds on the hemoglobin. Okay, feed, and then when it ruptures, giving out antigen, certain antigens, which can partly proteins, heme, and then this is becomes iron deficient. The cell becomes iron deficient, and then as you break more and more, there is sometimes jaundice because of hemolysis, and that was a stage where we call it severe malaria. And it's important that to remember that those who will be affected are the patients who are of less immunity. Pregnant ladies is a weight. Pregnancy is a weight on the human, on the female, and early childhood. Then again, this is a stage of weakness. Then we have patients who have clear low immunity, like HIV, because those HIV will have more. If they have malaria, it will increase the viral load, and if they have HIV, they are more prone to the severe malaria. So HIV is one, and even malnutrition. If you are malnourished, then your immunity will be decreased, and you can catch up the malaria easily. So these are the areas. Okay, we already said that there are four main species, which is falciparum, and the falciparum is called malignant malaria. It's the malaria which can cause complication. That's falciparum malaria. The others are called benign, but no disease is benign, but this is relatively benign, which is ovale and vivax and malaria. Okay, they are chronic, giving chronic pictures of malaria. They can become acute, but usually they are milder and they don't go into complications, which is almost restricted to falciparum malaria. Unfortunately, in the Sudan, the malaria is falciparum malaria, and in most African countries, it is falciparum malaria, which is leading to death. So, what makes falciparum malaria more malignant? Um, the the parasite inside the RBCs changes the morphology of the RBCs and becomes more adherent, cytoadherence of these cells to the endothelial walls. And the walls and the vessels are the microvilli of the brain, of other places, causing like obstruction. The adherence of these parasites, of these RBCs together, they form a bolus. And sometimes they even attract normal RBCs, which are not parasitized, and they cause a rosette form, which acts like a bolus and blocks the microvilli. And this is why you can get encephalopathy, you can get a disturbance of brain function. In children, you can get convulsions, seizures, and you can get coma, straight away coma. And this is due to vascular abnormalities, blockage of the microvilli, the RBCs causing, adherence and becoming the sort of a block, which is, and then certain RBCs, which if deformed already like RBCs, will be more adherent than others. So it's, if you go on, treatment has to be abrupt, has to be immediate, especially if it is severe. And WHO have given symptoms, signs of severe malaria. To us, or to me, I think these are of academic interest, okay? But it is definitely influence the prognosis, number one. Number two, it will influence the management of this severe malaria. But severity of malaria is something which will, no malaria, severe or not severe, should not be started as early as possible and treatment. So, what are the signs or what are the indications of severity? Simple. If you have any disturbance of any organ function, like brain, like coma, if you have hypoglycemia, then this is severe. If you have acidosis, because mainly if there is an increase of lactic acid, then again this is severe. And then if you have an acute kidney injuries, AKI, acute kidney injury, and the kidney injury is another sign of severity. And then if you have jaundice, again, this is another sign of severity. If you have pulmonary edema, then again, this is severe, this sign of severity. And what does it indicate? It indicates that treatment should be very abrupt, even without diagnosis. And when we say without diagnosis, you take a blood film for a Giemsa stain, thick blood film, and then start treatment. And luckily, artemether drugs, arsenate, which can be given intravenously, then it has a quick action. So don't hesitate to give artemether early. Unfortunately, this advice is taken sometimes to the other side. We are definitely over-treating malaria, because not all fevers are malaria. And even if you have a blood film and the clinical picture is not that of malaria, you have to think twice, because you thought that there is asymptomatic carrier of the parasite. And if there are asymptomatic carriers, then this may get typhoid, may get influenza, may get other causes of fever. So you have to balance the clinical picture and the parasitology and see if you are very confident about malaria. Remember that the symptoms, as we said it earlier, these are the symptoms which should be dealt with, like fever, sweating, rigors, and then if it goes to severity, disturbance of cerebral conscience, seizures in children, and then you get all the rest of the complications. So it's the coma. Coma is usually, luckily, reversible encephalopathy. Okay, and if you look into the fundus, there are certain changes which are very well documented now in cerebral malaria. One is whitening of the arterioles, and whitening is due to sequestration of the RBC of the vessels, whitening, and then you can have hemorrhage in the retina, cotton wool, and have papilledema. In most cases, in the majority of cases, these neurological deficits will go off. However, you can have, if there is too complicated, then you can have hemiparesis, you can have cortical blindness, you can have hemianopia and tremor. But in the majority of cases, then this is subsides. You may get some people who have permanent damage, but these are very, very small numbers. The other one is the acute kidney injury. Luckily, again, this is reversible. What happens is thus there is a vasoconstriction to the arterioles, to the renal tubules, and it is renal tubule damage, which can cause acute renal failure. And hemoglobin itself is can be deposited in the renal tubules and give you damage to the kidneys and leading to acute renal failure. Usually there is oliguria, there is no anuria. If there is anuria, this is a very bad prognostic feature. Then we talk about black water fever. This is a state of acute hemolysis. And black water is black urine fever. Okay, black water fever is referring to urine. It's black water urine fever. This is can cause massive hemolysis, and the hemolysis will deposit hemoglobin in the kidneys, and then the urine becomes dark, either black or deep brown urine. And this can happen as a complication of malaria or with quinine. This is known that if you give quinine, will give a chance more to black water fever. Okay, as we talked about hypoglycemia, and this is again a feature of severity, hypoglycemia can be a feature of its own right. But it can be a hidden clinical feature within a patient who is already very ill or comatose. So thinking about hypoglycemia in patients is very important. Okay, and then you can save the patient with 5% or 10% glucose in cases of if the patient is hypoglycemic. And in a patient with coma, it's always advised that you should repeatedly, almost every 4 hours, you should do the blood glucose level. So don't lose the patient because you are not aware of the hypoglycemia occurring. Okay, so that is another form of severe malaria. Lactic acidosis, as we have said earlier, it's air hunger, like heavy breathing, what we call osmosis breathing, and this is have to be treated by bicarbonate, correcting the metabolic acidosis which can occur with this with the cosmos breathing. So these are the symptoms or the complications which can occur with the disease. But we have to talk about pregnancy. The malaria in pregnancy can be severe, okay, and usually the immunity of the pregnant ladies is less, especially if they are not feeding well, if they are anemic. So what does it do in pregnancy? In pregnancy, and this is, as we said, the two groups, the children below 5 and pregnant ladies are the one who may get complicated malaria. And then it can cause acute symptoms like fever, whatever it is, headache, prostration, sweating, the usual one. But usually in pregnancy, it can cause a lot of effect on the pregnant ladies. It can cause stillbirth, can cause abortion first. It can cause low birth weight if you have repeated attacks of malaria. It can cause neonatal death or early neonatal death or stillborn even. So this is something which we should take seriously. Luckily, artemether or artemisinin can be given, or in combination can be given to pregnant ladies. We are very sure that they have no effect on the baby in the second and third trimester. But in the first trimester, there is doubt. But still, life of the mother is as important as the child. And if you are to wait, then the mother should live, having another chance of giving babies. But it is artemether is the drug of choice in these situations of pregnancy, which is very, very important to handle the lady's pregnancy with an obstetrics, gynecology patient, and monitor the baby repeatedly with ultrasound to see if there is neonatal, if there is fetal distress, or this can happen with malaria. So it's last time we talked about the chronic malaria. You can have sort of fatigue, and ill health, fever, and the rest of it. But it is overdiagnosed. Luckily, in Sudan, we don't have Bivax and Novali. These are usually in Southeast Asia. But chronic malaria, people are talking about chronic malaria. I don't think that it is. Malaria is more blamed than causing damage. So you have to be careful about diagnostic criteria of malaria. People talk about having malaria. Look at malaria, this is can be one of three things. Either it is not malaria, which is in most cases. This is why you have to investigate. Always, if possible, treat on a positive blood film, unless the patient is complicated malaria. This is why if somebody is drowsy or with coma, then you can't play around. You have to start, even if it is not malaria, do it, and then think about what we want to do further. So that is straightforward. But the chronic malaria may be relapsing malaria. You have been treated with malaria semi-adequately or adequately, but the parasite was there. It's been knocked, but not knocked completely. This is a relapse. And then you have the recurrence, okay, of malaria. And then you have the hidden malaria. You remember when we're talking about the cycle of the parasite, we said that the sporozoites, which are inoculated from the mosquito to the human, then goes into the liver to cause a schizont. And the schizont is multiplying and then breaks into merozoites. And the merozoites go and parasitize the RBCs. This is the normal routine. Some of the merozoites will go into the gametocyte to continue the cycle, and some of the merozoites are in the RBCs giving the ring form. But some of the sporozoites will develop into schizoid in the hepatic cells, and they become dormant, what we call hypnozytes. Hypnosis, meaning sleeping, hypnozytes, and these hypnozytes will go on and develop schisms, and the schism will be dormant. It will not break and cause acute fever. It will remain there as a dormant, hypnotized schisms. Okay, years, months, sometimes years after the treatment, after continuous treatment, then you can get a recurrence. Okay, this is an opening up of these hepatocytes, and merozoites can be thrown into the bloodstream to parasitize the RBCs. So this is actually it's a new infection. It's a new infection from an old hidden infection. Okay, this occurs only with Ovale and Vivax. This is why if you are treating an acute malaria with Vivax and Ovale, you have to give another drug to treat the schism, which are dormant schism, which is primaquine. Primaquine or primaquine, P-R-I, prima, I-M-A-Q-U-I-N-E, primaquine. Give it in ample dose, then by that you will have eradicated malaria in that particular patient. So unless you do that, you can still continue with a hidden malaria. So that is not a relapse. It is because of the hidden schistosomal. Okay, the time which is left for us, I would like to concentrate on the treatment of malaria. Okay, the great fear with treatments of malaria is development of resistance. We have been faced with resistance to chloroquine, which was very simple, cheap, easy to administer, but unfortunately we lost it because resistance we were faced by resistance, and the chloroquine is no longer used in most countries. So, and then we had quinine, which is from the cinchona tree, and quinine has been with us for a very long time. Okay, it's more toxic than chloroquine. Quinine can be given IV. Okay, diluted IV, never given as a bolus because it can cause hypotension, and it can be useful in cerebral malaria, can be combined with artemisinin. But the great blessing of God is the presence of artemisinin, and then the derivatives from that artemisinin. Artemisinin is a drug which was discovered in China, and it comes from the leaves. Artemisia annua, or Ginkgo. The drug is called also Gingasu. Artemisinin is called Gingasu. Ginga is QI. Usually, the Q is followed by U, but here it is QINGHASOU, Gingasu. Okay, and the plant is a shrub, which is called Artemisia annua, ANNUA, or Ginga. We use Gingasu, you call it Gingao, which is a plant. Okay, I'm concentrating on this because this is now the hallmark of treatment of malaria, and you are scared because it's the only very effective, rapid acting anti-malarial, and life is dependent. Our lives in patients who are working on malaria are dependent on artemisinin. Okay, so what is the derivatives? How can you use it? And we are talking about ACT. What is ACT? ACT is artemisinin combination therapy, and we are combining artemisinin derivatives with other drugs like lumefantrine, mefloquine, sulfoxone, okay, and other antifolate drugs, okay, pyrimethamine. These are other drugs which are combined with artemisinin derivatives. This is for fear of or reducing the chance of resistance. Okay, and this is known that if you combine two active drugs against a parasite, then resistance will be prevented or delayed, and we have that in ART for HIV/AIDS and antituberculous drugs. Antituberculous drugs are being given in triple or quadruple regime, which will reduce resistance. So ACT is of the same principle, using artemisinin derivatives to give a long-lasting effect of artemether. Okay, artemisinin itself is less effective. This is the parent drug or the mother drug, but there is other derivatives from artemisinin, which is artemether, and artemisinin. The spelling is clear. Okay, ARTEMESIN, artemisinin, NIN, artemisinin. Okay, and the derivatives number one is artemether, and it is ARTETE, artemether, METHER, artemether, and this is the oil soluble methyl ether of artemisinin. Is a derivative. Okay, this is oil soluble, and you remember oil soluble never given IV, as oil soluble drugs are only given intramuscular or orally. Okay, and then we have artesunate, artesunate, which is water soluble. Luckily, it's a water soluble hemisuccinate derivative. This is the water soluble, and the water soluble can be given in diluted form IV. And patients with coma or severe malaria or complicated malaria, we can rapidly give artesunate, and artesunate comes in. Artesunate will come into powder of artesunate acid, which can be dissolved. Artesunate acid, it comes in powder, it can be dissolved, okay, and then diluted in an ampoule of 5% sodium chloride. Usually, the powder comes with the diluent or diluent, which is dilute the drug, and then it is injected. It is given by dilution. If drugs given by dilution is either through normal saline or dextrose. So artesunate can be given intravenously, and artemether is given only. Artemether is given by IM, and it can also be given by capsules. And again, if you want to inject artemether, which is oil soluble, don't give it in the buttocks. Give it on the anterior part of the thigh, okay? Because of complications which might be caused. Artemisinin, the parent drug, can come into capsules or suppositories. Why suppositories? Because we have children who have severe malaria, and people in the villages where they don't have access to health facility nearby are being given suppositories. Okay, Rectucap direct to cup, which are in the house. If a child, is who has fever and drowsiness, suppository will be pushed in the rectum and then taken to the hospital. So we are saving time. We are saving time and saving life because of early treatment of the malaria. So Artemether, why we like it? Because it's rapidly acting. Okay, it also have a limited effect on the schizons. Okay, no, sorry, on the on the schizons and partially on the gametocyte. So it's a drug which is useful in the acute stage, in the chronic or hidden stage, okay, and on the gametocyte. Okay, so it's a drug which is well respected, and it made a lot of change in the life of people. There is Artesunate reduced in one study reduced mortality by 35%. That is in one study. And if you catch the patient early, even with major complication, then you can treat very amicably. So it's a rapid with wide window or broadest window, okay, time window of drugs, of activity, and it's very safe. Okay, it's very safe. The minor side effects is like hypersensitivity, type 1 reaction, but otherwise it's very well tolerated. And this is a great blessing, a great blessing. So you can treat with single drug or you can treat with combination ACT. Okay? The single drug usually by injection, all right, by IV or by injection, diluted injection of artesunate, and then by injection, artemether injection, and then is oral of artemether, okay, and oral for artesunate, and there is suppositories of artesunate. Okay, what is ACT? ACT is a combination artemether with another anti-malaria. Okay, you have different combinations. The drug which can be used in combination is lumefantrine, lumefantrine, or mefloquine, mefloquine, okay, or arsenate with sulfadoxine, and pyrimethamine. Okay, these are antifolates. And then arsenate with amodiaquine. So lumefantrine, lumefantrine, mefloquine, sulfadoxone, pyrimethamine, and amodiaquine. These are the drugs which can be combined with artemether, and these comes in tablet form, tablets or capsules forms, which can be taken as an outpatient for malaria, which can be treated as an outpatient. Okay, there are other group of anti-malarials, antibiotics, and antibiotics. The antibiotic which will inhibit protein or nucleic acid synthesis or nucleoproteins, these becomes useful in the treatment of malaria. Classically, doxycycline. Doxycycline is one of those drugs. Clindamycin is another drug, and sulfones. Okay, sulfones can be other drugs, but you cannot rely on antibiotics alone. You have to combine it with other drugs which you can treat malaria. Our greatest fear is resistance to these drugs. Our greatest fear. Up to now, we have some options, but if we lose artemether or the artemisinin derivatives to resistance, then we lose a very valuable weapon against control of malaria and treatment of malaria. And unfortunately, there are now reports from Southeast Asia about some resistance to Artemether. And this is up to now. Luckily, it is limited to certain areas in Southeast Asia, but in Africa and some areas in Africa, East Africa, but luckily it is by and large, the drug is still very effective. Okay, the management of complication is the management of the complication. If you have a patient with coma, then it is treatment of unconsciousness or the care of unconsciousness with feeding, urination, defecation, positioning. If it is an acute renal damage or acute kidney damage, then you may need, dialysis, acute dialysis. If it is something like black water fever, again, this is treated as a renal failure. If it is jaundice, usually it's either in the liver or hemolysis, then this can be treated accordingly. Pulmonary edema, you don't need to do a lot, Once you treat the acidosis, metabolic acidosis by bicarbonate, then you are treating the complication. During pregnancy, you have to follow up the patient very well, and the child and the baby inside with ultrasound, consulting the obstetrics and gynecology people, okay? With a child with convulsions, because this is kind of care in children, they have seizures with cerebral affection of malaria, then this can be treated as an epilepsy, not epilepsy, but these are the regime. You care about the patient not to fall, not to hurt himself, and then you can give diazepam, suppositories, or you can give anticonvulsant therapy. But usually, as we said, these complications, when you grow out of it, you don't get permanent epilepsy. So treat the complications as per complication and treat the malaria as we have outlined. And always think about how we prevent malaria. That is the issue, okay? People have eradicated malaria, eliminated the malaria, and this is the ultimate objective of our care. Okay, we care the patient, we treat early, we care about the mosquito, how to kill it, how to prevent breeding, and how to improve our environment as far as hygiene and health education is concerned. So I think that will cover most of the areas of malaria. And as far as the drugs, because the drugs we need to give the doses and the side effects, I will send you a one-page summary of the available drugs and the side effects and the way the doses which we can give, okay, and minor side effects, minor adverse effects, or severe adverse effects on each drug, and that will be sent to you by email or by WhatsApp. That will cover the malaria part. But remember that malaria is an important disease, and we need more effort to combat it and hopefully to eliminate it. Thank you very much indeed for being with me this morning, and we hope to see you on Sunday for another talk on tropical or infectious disease. Thank you. Bye.